In this video, we're going to talk about the mechanism of action of opioids. So that means we're going to look at certain things like fentanyl or morphine and how they're going to impact the body. When we're looking at opioids, we have to appreciate that there are numerous opioid receptors that live in different parts of the central nervous system and will have differing effects based on where they live. When we're looking at analgesic medications like fentanyl or morphine, we're primarily going to be looking at the impact of these opioids on mu receptors that live in the central nervous system, primarily in the cortical and subcortical regions of the brain. So we have mu receptors that live cortically and subcortically. We also have what are called kappa receptors that live more dominantly in the spinal cord, so kappa receptors. And we also have delta receptors that are going to live more dominantly in the periphery, or basically the nociceptors that are going to live in the periphery and be sending signals into the central nervous system. So we have these varying types of opioid receptors, and they are going to have different effects. When we're looking at things like morphine or fentanyl, they primarily are going to function on our mu receptors, which are living within the central or the cortical or subcortical portions of our brain, and have differing effects. So in order to understand the mechanism of action of opioids, what we'll do is we'll take a look at the actual neurons. So what we're looking at here is the presynaptic neuron, and this is the postsynaptic neuron. So presynaptic and then postsynaptic. And the whole function or goal here with these neurons is to have the release of vesicles filled with neurotransmitters from one side to the other. So the goal is, say I have glutamate here, that's my neurotransmitter. The goal is I want to have release of this glutamate into the synaptic cleft. It's going to bind to receptors on the postsynaptic membrane and will send that signal further down. We're looking at something like the mu receptor. So this here will be our mu opioid receptor. And when we have binding of our opioid, so we'll say this is something like fentanyl that has bound to the opioid receptor, a couple of things are going to happen. One is that we are going to prevent the conversion of ATP into cyclic AMP or CAMP. So ATP typically being converted by adenyl cyclase into CAMP. What happens here is this is prevented. So we can no longer convert ATP into cyclic AMP. So that is one of the big problems associated with an opioid, is that I am inhibiting the ability of adenyl cyclase to convert ATP into cyclic AMP. And that has a couple of consequences for the patient. One is that we have potassium channels that live on our presynaptic membrane. So these are potassium channels. So this is a K plus channel. And what happens when we inhibit the conversion of ATP into cyclic AMP is that those channels will open, and this will promote efflux of potassium. So potassium that's typically inside this presynaptic neuron, we see efflux. So we see efflux of potassium. And if we think about the consequence of that, or this efflux of potassium, what's going to happen is the cell will become more negative. We're losing a positively charged ion to the outside of the cell, or to the space outside the neuron. And the neuron has a number of negatively charged proteins that live inside it. So as we lose this potassium, the charge becomes more negative within the neuron itself. And the consequence to that is that it becomes harder to stimulate. If we think about what is happening in nerve transmission, we have sodium channels that are opening down this neuron to open more sodium channels. So we're having an action potential propagate. Well, if this area is more negative, it requires more sodium to stimulate it. And as a result, we see a reduction or cessation of nerve propagation or action potential propagation. So making the presynaptic membrane more negative can lead to less propagation of impulses, and as a result, we're not going to see this presynaptic neuron functioning the way that's supposed to. The other consequence that we see here is that we will close calcium channels. So we have calcium channels that live on the presynaptic membrane, and the function of this calcium channel is to allow calcium to enter, and the calcium plays an important role in pulling our vesicle down to the presynaptic membrane and releasing that those neurotransmitters. So we're actually going to, calcium will typically pull the vesicle down and support release of the neurotransmitter into the presynaptic cleft. Same thing, this is now inhibited here. So one of the problems is we close these calcium channels as a result of this loss of ATP conversion into cyclic AMP, and we have the inability to have that calcium influx. So if we think about the issues, the problems associated with binding of the opioid to the mu receptor on the presynaptic membrane, one is we see increased opening and efflux of potassium. So our potassium channels open, which leads to an increased efflux of potassium. The other issue that we're going to see here is we have closure of calcium channels, which is going to impair the ability of vesicles to make their way to the presynaptic membrane. So basically we lose the ability to have the release of our neurotransmitters into the synaptic cleft. We do see our opioid receptors, or some opioid receptors, living on the postsynaptic membrane. So we do have some mu receptors that live postsynaptically. And when a mu receptor binds postsynaptically, it actually will have a similar function in preventing activation of the postsynaptic membrane. So when we have binding of an opioid, the third thing that we see is decreased conductivity in the postsynaptic neuron. So that is the overall consequence of our binding of an opioid. We bind to our mu receptors, which is going to lead to opening of potassium channels and efflux of potassium, which hyperpolarizes the presynaptic membrane. We close our calcium channels, which is going to lead to the inability to have vesicle release of neurotransmitters into the presynaptic cleft. And we actually just make the postsynaptic neuron harder to stimulate, so we have less propagation. So essentially, we're shutting down nerve transmission at these areas that we're looking at. Now, in some cases, that has a benefit. So if we think about one of the things that we want to do is we want to reduce pain perception. So fentanyl or morphine or our opioids are going to have a powerful role in analgesia or preventing pain transmission. So if we think about what that typically looks like, when I experience pain in the periphery, that is recognized by nociceptors, so they are going to recognize the pain. They use somatic nerves to send a signal to the spinal column. The spinal column does act like a gatekeeper, so it will then, or typically will send the signal up to the cortical regions and subcortical regions of the brain to have the conscious perception of pain. So it is sent to these subcortical regions of the brain, where the brain will provide us with the conscious experience of pain. So the benefit of something like an opioid is that when we bind to these mu receptors, we decrease the ability of that impulse to be recognized by the subcortical regions of the brain. So one of the benefits here is that we see an analgesic effect, because we're reducing the ability for pain impulses to actually stimulate the central nervous system. So we see decreased perception of pain impulses, and that's how we get the analgesic effect that we're looking to have with this. Now, we see a couple of other things, a reduction in activation of some of the neurons that we see bound to by the opioid and the mu receptors in the central nervous system will lead to euphoria. So often we see an increase in patient comfort as a result of the binding to mu receptors. But there are also a few unintended consequences. So when we look at our mu receptors, we also have a fairly high density of mu receptors within the medulla, or the respiratory centers of the brain. And what can happen here is we actually see the reduction in the ability of our respiratory centers, or the chemoreceptors, to send signals to the respiratory units or the lungs to encourage breathing. So one of the kind of negative consequences of an opioid is that we start to see decreased chemoreceptor transmission to our respiratory system. So in this case, what we can actually see is the patient will have a reduction or decreased ability to respond to things like hypercarbia, so an increase in CO2, or hypoxia or acidosis. Finally, with the use of opioids, we will often see patients present with pinpoint pupils. And the reason for this is that the ability to manage pupillary response involves an inhibition or activation of the oculomotor nerve, which is going to send out signals to the eye itself. So what we see here with the eye is we have our oculomotor nerve, which is going to send impulses to either have pupillary contraction or pupillary dilation. This happens through either activation or inhibition of the nerve, and we have different centers that are going to provide either of these things. What happens when we take an opioid is we no longer have the ability to inhibit, so we don't have the ability to inhibit this nerve, and what will happen is that will promote consistent pupillary constriction. So as a result, what we see with these patients is pinpoint pupils, because we get consistent constriction of the pupil itself, so pupil constriction. So when we're looking at our opioids, we know typically they're binding to our mu receptors within the central nervous system and the cortical and subcortical regions of the brain. What they're going to do is promote efflux of potassium and hyperpolarize the cell while preventing calcium influx because we've inhibited adenocyclase's ability to convert ATP to cyclic AMP. The consequence of this is we have less vesicle release of neurotransmitters, less neurotransmitters in the synaptic cleft, which means less stimulation of the postsynaptic membrane. The other piece that's going to happen here is that binding of the mu receptor in the postsynaptic neuron will also decrease the ability to respond. And overall, we have less nerve transmission in the areas of the brain impacted. The benefits of this is when we give a narcotic to people is that we can see a reduction in pain perception because we're not processing the impulses coming from the periphery to say, hey, we're in pain. And we also can see some euphoria. Some of the other consequences can be respiratory depression because the chemoreceptors will no longer respond to things like increasing CO2, reducing O2, and acidosis. What this means is less stimulation of breathing, which can promote apnea and hypercarbia in these patients. Finally, we often will see pinpoint pupils because we lose the ability to inhibit the ocular motor nerve, which is going to promote constriction of that pupil or having a smaller pupil as a result.